Welcome, everyone. My name is Dion Ellis, and I'm a graduate of UNM School of Medicine and a member of the Black History Month Planning Committee. So before we begin, I would like to welcome everyone to the HSC Office for Diversity, Equity, and Inclusion Black History Month's event. On behalf of all of us, thank you for making time to join us today. For those who could not be here today, this presentation will be recorded and posted on our website. At this time, I just wanted to go over a few housekeeping items. First, we will be using Zoom webinar format. This doesn't allow participants to address the panelists directly, but rather through a Q&A function that you can see at the bottom of your particular Zoom account. Please place your questions in the Q&A box at the bottom of your screen. We will try to address and get to as many questions as we can by the end of the presentation. Also, you can see the panelists, but the panelists cannot see you, and the chat is not available for this Zoom webinar. With that said, I would like to take a brief moment and introduce our wonderful guest speaker here today. So Dr. Anita Fernander is a graduate of Oakwood University in Huntsville, Alabama, where she majored in physical education and psychology. She received a master's degree and a PhD in clinical health psychology from the University of Miami and completed her postdoctoral work fellowship at Mayo Clinic School of Medicine. Dr. Fernander was recently appointed as the Executive Diversity Officer in the School of Medicine in the College of Health Sciences at University of New Mexico. Prior to joining UNM School of Medicine, she served as the inaugural Chief Officer for Justice, Equity, Diversity, and Inclusion at the Charles E. Schmidt College of Medicine and interim department chair and professor in the Department of Population Health at Florida Atlantic University. Dr. Fernander also served on the faculty in the University of Kentucky's College of Medicine for 19 years, where she held key diversity roles. She was founding faculty of the Center for Health Equity Transformation and received the inaugural Diversity Champion Award, as well as the inaugural Excellence in Diversity Faculty Award. She has been engaged in leadership, teaching, research, and community engagement to address health inequities, enhance patient advocacy through cultural humility, and exploring transformational interventions to address historical and contemporary racism embedded in the political and social determinants of health. Her primary area of research has focused on the impact of race-related stress on health inequities among African Americans. And without further ado, and with great honor and privilege, I present a mentor, a colleague, and a true inspiration, Dr. Anita Fernander. Dr. Fernander, the floor is yours.
Thank you, Dr. Ellis. Thank you so much for that beautiful introduction. It's greatly appreciated. And I also just want to extend thanks to Dr. Sanchez and the Black History Month Committee for allowing me to present on this topic this afternoon. I'm going to go rather quickly through my presentation this afternoon, but I want to start this afternoon by acknowledging our Indigenous peoples, land, as well as labor. So at UNM, we respectfully acknowledge the traumatic history of forced labor. Excuse me, I'm reading the wrong acknowledgement. Let me read the first one. Founded in 1889, the University of New Mexico sits on the traditional homelands of the Pueblo of Sandia. The original peoples of New Mexico, Pueblo, Navajo, and Apache, since time immemorial, have deep connections to the land and have made significant contributions to the broader community statewide. So we honor the land itself and those who remain stewards of this land throughout the generations, and also acknowledge our committed relationship to Indigenous peoples. We gratefully recognize our history. At UNM, we also respectfully acknowledge the traumatic history of forced labor of African Americans who have advanced our country. We are indebted to the enslaved and exploited African Americans who established our US infrastructure and economy, advanced civil rights, and continue to influence popular culture. We are obligated to continuously recognize historic and current systemic oppression and injustices placed on African Americans. We are grateful to their ancestors, for without them, we would not be where we are today. So attacks on critical race theory in the US have increased over the past few years, and most notably, the wave of attacks began on September 2020 when former President Donald Trump issued an executive order banning federal government employees, contractors, and grantees from promoting or providing diversity trainings that were deemed to be divisive concepts. Critical race theory was specifically highlighted in that executive order and was categorized as being un-American propaganda. So while the executive order was promptly rescinded by President Joe Biden on January 2021 when he came into office, the effects of former President Trump's executive order had already trickled down to the state level, where many localities began to introduce legislative bills seeking to restrict institutions that receive federal funding from teaching versions of American history at all educational levels that were interpreted as destructive, anti-American, or anti-patriotic. This assault on American freedom, American expression, and our ability to not repeat history is truly short-sighted and mischaracterizes the dynamic and interdisciplinary field of critical race theory. So my goals for this afternoon's presentation are to clarify what critical race theory is not, and to clarify what CRT is, provide a brief historical and contemporary review of the construct of race in the US, and apply CRT to the field of academic medicine by describing how race and racism are embedded in the political systems and social structures that have created inequalities, resulting in persistent health inequities exemplified among the racialized population of African Americans. So let's dispel some CRT myths at first. CRT is not simply engaging in the instruction of historical facts and information. Rather, CRT is an analytical and critical approach to understand how racialized historical contexts influence in contemporary society and structures. CRT is not taught in elementary and secondary educational settings. Children at these educational levels have not reached a level of intellectual maturation to apply and engage in such critical and reflective analysis. That is, CRT is not utilized as a pedagogical approach to teaching American history to elementary and secondary learners, as it is incompatible with the typical developmental and intellectual capacities of students in these stages of learning. In addition, a study conducted by the Association of American Educators found that 96% of teachers reported that CRT is not and has never been mandated for them to teach in elementary and high school settings. CRT seeks to acknowledge and encompass all of American history, the good, the bad, and the ugly. It's not anti-white, it's not anti-patriotic, nor is it anti-American. However, some might conclude that CRT is in fact anti-racist. CRT does not seek to incite guilt or shame among white Americans who may be far removed from the perpetrators of harmful, racist, historical, and social onslaughts. Rather, CRT seeks to stir shared communal understanding, compassion, empathy, and ultimately united grief that sparks what Valerie Kaur refers to as revolutionary love. So just a little background on CRT. It emerged in the late 1970s and 80s by legal scholars to examine connections between race history and the law in response to the unfinished work of civil rights and the erosion of many legal protections that have been enacted in the 1960s to protect the rights of African Americans and other minorities. Legal scholars sought to demonstrate through critical and theoretical study and reflection on race in US history that the country was nowhere near being post-racial, that color blindness was not a solution to address the social problem of racism in America, and that rather than simply existing as an individually or interpersonally experienced event, racism is foundationally embedded into American systems and social structures. So branches of CRT have evolved over the years with a focus on the particular experience of Indigenous, Hispanic, Asian American, and other racialized groups in America. CRT seeks to understand the roots of why racial disparities are so persistent and to systematically dismantle racism. CRT is applied to help understand racialized disparities in the fields of economics, education, medicine, and many other disciplines. It is a method that takes the lived experience of racism seriously, using history as social reality to explain how racism operates within cultural context towards the end of eliminating the harmful effects of racism and bring about a just, equitable world for all. So as long as racialized social inequities, racialized economic inequalities, or racialized health disparities exist, it is inaccurate to state that we in the United States live in a post-racial society. The US has long exhibited racial ethnic health disparities, and despite decades of concerted attempts to decrease or eliminate such disparities, disparities in health between certain racial ethnic populations and white Americans have continued to widen, not narrow. The application of CRT to academic medicine provides context for understanding racial disparities and ultimately providing solutions to address health disparities, inequalities in the political and social determinants of health and healthcare inequities experienced among racialized populations in the US. I want to quickly distinguish between a few terms. Health disparities refer to population-specific differences in the presence of disease, health outcomes, or access to care. Health disparities are well documented among racial ethnic minorities in the US. For example, at every stage of life, Black Americans have poorer health outcomes than white Americans. While health inequities are health disparities that are due to avoidable or remediable differences in health among groups of people. Political and social inequalities create health disparities among traditionally marginalized groups. And I want to highlight that political determinants are the drivers of social determinants. And I will discuss this a little bit further in my presentation this afternoon. But for the purposes of illustration, and as an initial primer, I will apply CRT to highlight health inequities experienced among African Americans by succinctly outlining the historical and contemporary context of the construct of race in the US and provide a broad overview of how racism is embedded in the political and social systems that have created inequalities that have led to the troubling state of African American health. This is something that I typically do over 2 semesters within my courses. So I'm trying to do that in a very, very brief time this afternoon with you all. So let's take a brief reflective journey of the lived experience of African Americans since the first documented African arrived on US soil in 1619 by starting with the construct of race. So race in the US is a relatively modern idea. In fact, slavery predates the construct of race in the US. The concept of race did not originate with science. However, scientists have played a pivotal role in constructing and legitimating race for centuries with the use of scientific racism. Scientific racism emerged in the late 18th century to validate existing racist ideas and prove a natural hierarchy of groups through a concept called biological determinism. Biological determinism posited that there were innate racial differences that required Blacks to be slaves and whites to be masters through a color-coded, economically driven system. Now, the US was founded on the radical principle that all men are created equal. But our economy was founded on an economic model of stolen land, stolen people, and stolen labor through the race-based system of slavery. Early attempts, as well as contemporary efforts to define the races of man through biology or genetics, have never been successfully accomplished. No amount of research into the genetic or phenotypic features of individuals or groups explain the socio-political phenomena of race. Not one characteristic, trait, or even gene distinguishes all the members of one so-called race from all the members of another so-called race. Now, this doesn't mean that the existence of race as a socio-political phenomena has no impact on the biology of human beings. The effects of racist ideology on the biology and behavior of individuals and groups has had devastating effects to where race has become biology, and evidence regarding how race is politically and socially constructed by racist ideology better positions us to identify the intergenerational biological consequences of being Black in the US. And I briefly illustrate this as follows. So while dated by 3 years, I like to use this illustration as it clearly demonstrates the number of years across which Blacks in the US suffered under slavery and Jim Crow segregation, compared to the amount of time struggling what I often refer to as Civil Rights 1.0 from 1965 to 2020, and Civil Rights 2.0 from 2020 to current times. So it was a conscious decision that Africans would become the laborers of choice. Africans could be uniquely and readily identified so that when they ran away, they could be distinguished from white indentured servants and couldn't just meld into the general population. So with the hardening of slavery came the emergence of race. So during the 246-year period between 1619 and 1865, physicians and scientists went to great lengths to prove that Black bodies were biologically and physiologically inferior from white bodies. These physicians and scientists used their expertise and pseudo-empirical data to insist that enslaved Africans were fit for slavery and that the institution was not immoral, nor was it cruel. And over time, their theories became incorporated into and normalized in medical practice. And this racializing of medicine did not end after slavery. Almost 250 years of enslavement from 1619 to 1865, where slave codes and land grants played a vicious role in causing injury to Black health because these laws equated the status of Blacks to little more than livestock and not fully human, thus disregarding Blacks' health accordingly. During this period, Blacks were deprived of healthy living conditions and healthcare, where minimal healthcare was only provided if economic loss was at risk. Even though their bodies were abused for medical experimentation without benefiting from the medical advances of those experiments. And some records document Black slaves suffering and dying from maladies for which whites received very basic medical treatment. 100 years of Reconstruction and Jim Crow segregation from 1865 to 1965 with legalized, unequal, and inadequate healthcare facilities, access, and treatment for Blacks. Laws were instituted that inequitably distributed resources such as clean housing, safe employment, and healthy food. Black codes were laws instituted in the South to keep free Blacks subordinate that regulated all aspects of their lives, from voting rights, employment, travel, education, jury service, marriage, and religious assembly. And in the North, zoning laws and restrictive land covenants made segregation legally enforceable. So that not only were desirable neighborhoods reserved for whites, but also unhealthy, hazardous locations were designated as sites for minority residences. Furthermore, during the first half of the 20th century, racism in healthcare became expressly legal as the separate but equal policy of the 1896 Plessy versus Ferguson case mandated segregation in private and public facilities, including hospitals across the nation. The 1946 Hill-Burton Act supported the separate but equal policy until 1979. So throughout almost the entirety of the 20th century, Black patients were relegated to less well-staffed, equipped, and appointed facilities where they received inferior quality healthcare. And over 58 years of civil rights from 1965 to date, where explicit and implicit racial bias continues to impact clinical interactions and treatment outcomes, in addition to societal and legal indifference that contributes to the destruction and the health of African Americans. So since the first documented African was brought to US soil in 1619, 61% of the African American existence as an inhabitant of the US has been enslaved residents, and the remaining 39% of their habitation on US soil has been embroiled in a struggle to have their lives matter and be recognized as full citizens with equal rights and equal access under the law and US Constitution. So this equates to over 400 years of historical and contemporary dehumanization of African American bodies, as well as inhumane healthcare. Scientists have also recognized that the interpersonal and individually mediated racism experienced by Blacks in the US triggers stress responses that damage immune, hormonal, neuronal, and epigenetic processes that lead to negative physical and mental health outcomes, exacting a heavy toll that has been linked to higher rates of morbidity and mortality among African Americans. So in addition to US medicine's legacy of segregation and racism is linked also to the current paucity of African Americans enrolling in and matriculating through medical school and practicing medicine, and the subsequent disparate health status of African Americans. History has demonstrated that Black physicians are more likely to care for Black patients than are white physicians and have better health outcomes as a result. However, for most of the late 19th century and for the first half of the 20th century, most medical schools prohibited Blacks from enrolling, and the few that admitted Blacks enrolled very few Blacks. Before the strides made by the civil rights movement and the establishment of affirmative action programs, most Black physicians trained at Black medical schools and practiced in Black hospitals. And these hospitals were vital and important institutions within the African American community. As many as 14 Black medical schools existed in the decades following the end of slavery, and by 1910, only 7 schools had survived. Since 1923, only 2 of those schools have survived to date: Howard Medical School and Meharry Medical College. So what accounted for this decline? The Flexner Report of 1910. The Flexner Report set standards for hospitals and medical training facilities that many Black facilities could not meet. And the significant decline in medical training facilities for Black physicians to train and practice resulted in a decrease in the number of Black physicians, while the number of white physicians increased. And this had a dramatic impact on the health of Blacks in the US, as fewer physicians were being trained to treat them. Only 2 Black medical schools were established after the Flexner Report of 1910. Charles Drew Medical School in 1966, which we heard a little bit about maybe last week or a couple of weeks ago, as part of our Black History Month observation. And then Morehouse School of Medicine was established in 1975. And it wasn't until 1969 that all of the nation's medical schools combined enrolled more Black students than did Howard Medical School alone or Meharry Medical School alone. Memberships in America's professional organizations, including the AMA, which was established in 1847, was restricted to whites only. Medical school membership provided, medical society membership provided benefits of professional advancement, forms to present papers and learn the latest techniques and treatments. Membership in AMA also provided a network where colleagues could rely on one another for medical advice and assistance. Furthermore, society membership was tied to referrals, hospital admitting privileges, licensure, and training. For over 100 years, the AMA actively reinforced racial exclusion. Non-membership in the AMA for Black physicians increased professional isolation, resulted in fewer referrals, and placed limitations on educational opportunities and sources of income. So this forced African-American physicians to create their own separate organization in 1895, the National Medical Association. And today, the National Medical Association is the nation's oldest and largest inclusive professional medical organization. The AMA left it up to state and regional AMA societies to determine their own inclusion policies. In 1964, the AMA passed a resolution stating that it is unalterably opposed to the denial of membership in county state medical societies based on race, but without any enforcement provisions in that resolution. And this stance remains to date. For most of the 20th century, before the strides made by the civil rights movement and the establishment of affirmative action programs, most Black physicians practiced and many Black patients received care in Black hospitals. And the passage of civil rights legislation in 1964 and Medicaid and Medicare legislation in 1965 mandated integration. And one of the most significant consequences of this legislation was the closing of Black hospitals. Between 1961 and 1988, 70 Black hospitals either closed or merged with white facilities, which had profound and devastating effects in minority communities. Many civil rights activists at that time believed that the integration of medical facilities would be a two-way process. Black patients and staff would integrate white hospitals, and white patients and staff would integrate Black hospitals. But this assumption was overly optimistic, as integration proved to be a one-way street out of Black hospitals. In 1919, 118 Black hospitals existed in the US. In 1944, there were 124 in operation. By 1993, the number of historically Black hospitals had declined to 8. Only 2 of the traditional Black hospitals exist in 2023. Riverside General Hospital in Houston, Texas, and Howard University Hospital in Washington, DC. So let's move now into a more contemporary view of race and medicine in the US. As the race idea evolved in the US, white superiority became common sense. Although individuals can indeed be racist, racism and its outcomes are perpetuated in society through social processes above and beyond individual actions. And racial practices have been institutionalized within the infrastructure and systems of American government, laws, and society. So race is a powerful social construct that provides differential access to opportunities and resources. And our government and our social institutions have created advantages that disproportionately channel wealth, power, and resources to whites. This affects all of us, whether we are aware of it or not. It is a fundamental reality of persistent structural and systemic inequalities that have existed in the US for several centuries that lead to health inequities among African Americans, as well as other marginalized racial groups. I want to talk a little bit more about the political and social determinants of health now. So Dr. Daniel Dawes describes political determinants of health as policies that determine the social determinants of health. Political determinants of health involve the systematic process of structuring relationships, distributing resources, and administering power. Racist political determinants of health and inequalities are legalized discriminatory policies embedded within the structures and systems that create the social determinants of racial health inequities. All health inequities can be traced back to a political determinant, even when the inequities are deemed to be the direct result of a social determinant. Health inequities owing to political actions or inaction have become so structurally entrenched that it has been difficult to identify their root causes. Critical race theory elucidates how institutions, systems, and policies can be designed in ways that codify and perpetuate exposures, risks, and opportunities that differ between racial groups, and the failure to invest the time and resources necessary to understand, manage, and leverage political determinants of health is why it is difficult to stem the tide of inequalities and achieve racial health equity. We're all familiar with the social determinants of health, which are social conditions and environments where individuals are born, live, work, play, pray, age. They include factors like economic stability, neighborhood and physical environment, educational opportunities, employment, community and social context, the healthcare system, and racism that is both embedded within these social determinants and interpersonal racism that is a part of the day-to-day personally lived experience of racial ethnic minorities, including African Americans. And these political and social determinants account for up to 80% of health risks. So I want to briefly highlight some of the racial inequalities within the social determinants that contribute to health inequities among African Americans. Financial stability is a fundamental health risk factor. Key variables include poverty, wealth, and employment wages. And when it comes to poverty, African Americans are more likely to be poor, have twice the poverty rate, and have significantly lower household income than whites. The combined wealth of all the Black people in the US, including Oprah, Michael Jordan, Jay-Z, Beyonce, Barack Obama, LeBron James, and Robert Smith, does not add up to the wealth of even one of the richest white men in America. In fact, a Black person has better odds of winning the Mega Millions jackpot than becoming a Bill Gates, because the lottery is completely random, meaning that everyone has the same odds. However, scientific research suggests that everyone does not have the same odds of becoming a CEO or landing venture capital funding, even if their qualifications are identical. On average, whites have approximately 10 times the wealth of African Americans, and one of the most important ways to initiate wealth is through home ownership. Home ownership for African Americans is at 41%, the same as it was in 1968, compared to 73% for whites. Due to lack of inclusion in the financial system, redlining policies that continue to date, and discriminatory home appraisals when African Americans put their homes up for sale or attempt to refinance their mortgages. William Darity, author of the book From Here to Equality, has stated that wealth and home ownership is the most powerful indicator of the intergenerational effects of white supremacy on Black economic well-being. There also exists a history of occupational segregation by race, with nearly 25% of African Americans employed in the service industry compared to 16% of whites. African Americans with similar educational levels as whites make less for the same jobs. African Americans are twice as likely to be unemployed than their white counterparts. Cornel West has stated that the US is the only developed country that has a class of people designated as the working poor. That means a 40-hour work week is not enough to provide for the basic needs of individual workers and their families. Educational attainment is a well-established social determinant of health. Key factors that impact education include early childhood education and development, high school graduation, and enrollment in higher education. African Americans have less access to high quality education at every stage of life. Only 19% of African American children attend early childhood education programs, compared to 42% of their white counterparts. African American students are also more likely to attend schools that are separate and unequal, from kindergarten all the way through high school. We know that place matters when it comes to health. It's been said that your zip code matters more than your genetic code. Since the 1930s, racialized redlining, predatory exclusion, and predatory inclusion, as well as racialized taxation, have continued to shape the neighborhoods and environmental living conditions of African Americans. Health is adversely affected by neighborhood characteristics such as air pollution, poor water quality, lack of available green spaces, and distant healthy food options. The African American poor frequently live in substandard housing that lacks heat, hot water, and electricity, and have high exposure to mold, asbestos, lead, and pest infestations. It's been noted that the top 10 US counties with the highest food insecurity rates are all at least 60% African American. And African Americans are twice as likely to experience hunger than whites. African Americans at all socioeconomic levels are exposed to higher levels of air pollution and live in close proximity to toxic waste sites. Majority African American communities are least likely to have access to hospitals and other healthcare providers. And research has linked disparate impact of climate change with redlining. For example, neighborhoods that were once redlined see more extreme heat in the summer than those that weren't redlined. Redline neighborhoods, which remain lower income and more likely to have Black or Hispanic residents, consistently have fewer trees and parks to help cool the air. They also have more paved surfaces, such as asphalt lots or nearby highways, that absorb and radiate heat. Redline neighborhoods of today radiate heat 5 degrees hotter in the summer on average than areas that are not redlined. And some cities have seen differences as high as 12 degrees. So even small differences in heat can be dangerous. During a heat wave, every 1 degree increase in temperature can increase the risk of dying by 2.5%. Higher temperatures strain the heart and make breathing more difficult, increasing hospitalization rates for cardiac arrest and respiratory diseases like asthma. In addition, researchers have found that excess heat can affect mental well-being and increase anxiety. So racial equity and climate equity are inherently entwined. Some of the key factors that often interact to impact community and social context include social and economic cohesion, homelessness, the criminal justice system, racialized policing, and civic engagement. Political underrepresentation and disparities in public services and investments in public goods makes African Americans less likely than whites to live in communities that facilitate social and economic mobility. And when it comes to homelessness, African Americans make up 40% of the homeless population and are overrepresented in every state. Racialized policing has continued since the time of those enslaved on plantations. The incarceration rate of African Americans in prisons and jails is more than 6 times the white incarceration rate. And these figures aren't due to the fact that African Americans commit more criminal acts than other racially classified social groups. When it comes to civic engagement, we continue to see evidence of bias in voting rights and access through rigid voter ID laws, voter purging, the closing of polling locations in African American communities, and voting restrictions that are placed on those with criminal records. African Americans face inequities in healthcare access and treatment, including preventive services, acute treatment, chronic disease management, and the quality of care received that all impact health disparate outcomes. For example, African Americans are least likely to have medical insurance, more likely to be underinsured, less likely to see a medical provider, least likely to have a primary care provider, least likely to be satisfied with their clinical encounter, and more likely to incur substantial medical debts than their white counterparts. An often overlooked fact related to race-related health disparities is the fact that racial health disparities transcends class and socioeconomic status. Even well-educated Black individuals with access to healthcare are more vulnerable to a number of serious diseases. Medical sociologist Dr. Sherman James coined the term John Henryism, which is a construct that I explored as part of my dissertation work almost 30 years ago. John Henryism originally posited that African Americans who resided in rural areas exhibited high effort coping in response to stress in the face of low socioeconomic resources were more likely to be diagnosed with hypertension. The results of my dissertation findings concluded that African American men who resided in urban settings and were categorized as middle to upper class were more likely to exhibit hypertension as a result of actively coping with stress than were African American men of low socioeconomic status. The impact of interpersonally mediated racism on the health status of African Americans does not discriminate when it comes to social class. In fact, Arlene Geronimus, a professor at the University of Michigan School of Health, coined the term weathering to explain how high effort coping in the face of continuous racial insults exacts a physical price on the bodies of Black Americans. There have been two periods in US history where health reforms from a social justice perspective specifically address the correction of race-based health inequities. The first was a 7-year period between 1865 and 1872 that was linked to the Freedmen's Bureau legislation during Reconstruction that mandated separate hospitals and clinics be constructed to serve free Blacks. The second was a 10-year period during the Black Civil Rights Movement between 1965 and 1975 to correct the damaging impact of the Flexner reports, which closed Black serving medical schools and hospitals and clinics that I spoke about earlier. So after 350 years of legalized medical neglect, only 17 years in this country's history were intentionally dedicated to legally addressing racial health inequities experienced by African Americans. Dana Bowen Matthew, who is a legal scholar, points out in her book, Just Medicine, that at several historic moments, the trajectory of racial inequality could have been altered dramatically, but at each juncture, the road chosen did not lead to a just and fair America. The Civil War and Reconstruction era each offered openings to produce a true democracy thoroughly inclusive of African Americans. Had the New Deal Project and GI Bill fully included Black Americans, the nation would have widened the window of opportunity to achieve an equitable future. And passage of sufficient civil rights legislation in the 1960s might have unlocked the door for America to eradicate racism. However, at none of these points was the path to full justice taken. Because an individual's health is significantly determined by political and social determinants, and the existence of health disparities and healthcare inequities are due to structural and systemic factors, it therefore follows that a social justice framework for addressing health disparities be undertaken. Injustice and inequality go against our professed national identity. Healthcare training that ignores social justice and medicine leads to incompetence and encourages malpractice. It's professionally irresponsible for academic medicine not to properly and fully educate faculty and trainees about the full history and lived experiences of the varied populations in the United States that have produced a citizenry that is rich in diversity and culture. Fallacies like Black individuals' immunity to pain, extra thick skin, and weakened lung function that were introduced into the scientific literature by racist doctors continue to show up in medical education by uninformed but so-called non-racist doctors who educate medical trainees today. Academic medicine should be deeply concerned about the current movement to ban the use of CRT, as they are fundamental to a scientific understanding of racial inequality in every type of social, economic, and health outcome across traditionally marginalized populations. So some of the key takeaways from this afternoon's primer is that CRT is not a history lesson in the traditional sense of the term, but an analytical approach to understanding the impact of historical events on racialized groups living within contemporary political and social contexts. CRT must be appreciated as a conduit with which to educate about the history of systematically racialized and marginalized communities and understand the political and social determinants that have created health inequities in these same communities over generations. Disparities when it comes to the health of Black people's bodies is rooted in false ideas about racial differences developed and spread during slavery that still inform the way medical treatment is administered in America. It is racism, not race, that drives and explains racial differences in almost every political, social, and health outcome. CRT seeks to stir shared communal understanding, compassion, empathy, and ultimately united grief that sparks a revolutionary kind of love that in turn fans the flames of advocacy, activism, and transformative justice. It is only then that academic medicine stands the chance of raising consciousness at all levels and effect meaningful and lasting changes that are necessary to create a healthy and empowered country, a country that is reflective of its global status as a diverse superpower. Historian and documentarian Ken Burns has stated, being an American means reckoning with a history fraught with violence and injustice. Ignoring that reality in favor of mythology is not only wrong, but also dangerous. The dark chapters of American history have just as much to teach us, if not more, than the glorious ones. And often the two are intertwined. I posit this afternoon that whether racial profiling within policing or racial profiling in healthcare, they both contribute to unnecessary disparate morbidity and mortality among African Americans. Health equity is both a process and an outcome. It is both a journey and a destination. We must educate ourselves about the history of our communities and understand the political and social determinants that have driven these inequities in our communities for generations. James Baldwin says, the price one pays for pursuing any profession or calling is an intimate knowledge of its ugly side. I want to thank you so much for paying attention to the presentation, for participating. And I just also want to share that if you would like a copy of the bibliography as is seen on my final slide, I can forward that to you. Just forward an email to me and I will get that to you. I'm going to turn things over back to Dion if there are any comments or questions in the chat or that folks want to place in the chat that they would like for me to address. I am happy to do that.
Well, thank you so much, Dr. Fernander, for that wonderful and informative talk and presentation. Really appreciate you taking the time out of your busy schedule to present this very pertinent topic to not just members of HSC, but also members of the community. So we do have a few questions in the chat, and I encourage other people to continue to post their questions and comments. But one of them talks about the statistic that you brought up about 80% of health outcomes being influenced by social determinants of health. This individual would like to use that kind of statistic in some of the work that that individual is doing, and was wondering if you happen to have a citation for it. I assume it's in that final slide. Yeah.
Absolutely. I can share that. If that individual will shoot me an email, I will share that citation.
Okay, wonderful. And next question. So this individual is a parent of middle school students and was just wondering if you could kind of elaborate or discuss a little bit more the assertion or the comment that CRT is not developmentally appropriate to teach in a K-12 setting.
So I would say that traditionally, developmentally, that's not to say that there aren't exceptions, that CRT is not appropriate for K through 12, maybe more for the upper ranges of high school. I think that when it comes to having a critical lens and an analytical lens on facts and applying them to contemporary status, that's not something that we traditionally or developmentally believe that young children can do. So generally, we do provide the history lessons. We provide the facts about history. And as we move into our undergraduate and upper level studies, we are able to take the time to critically analyze a lot of the things that we learn. There are books that I can refer you to on CRT that kind of describe this a little more that may not be in my bibliography, so I'm also happy to provide. I think that CRT, there's a whole history. I don't want to get too much into it, but CRT has been a target. And the target really is providing history. I think what we're trying to do as educators is to promote and continue to educate, provide the history lessons. CRT has been conflated with those history lessons. They're two separate things. So that's kind of how I address that concern.
Wonderful. We have the next question is a two-parter. So the first part of this question is, why do you think there has been such great pushback against CRT? And then secondarily, why do you think that disparities have continued to widen despite some of the progress made over the last few decades?
CRT, I don't remember the organization. There's an organization that's based in Washington, D.C. They have individuals who just really kind of identified CRT as a construct, as a concept that they were going to utilize. I almost think it's almost a random thing, but it wasn't so random, but that they were going to utilize to discourage the teaching of the ugly side of history in this country. That is the only explanation. If you look up, I don't know why I'm blanking on her name, developed the construct of intersectionality, as well as was one of the, I I know it's here somewhere in my bibliography of CRT. She talks about how CRT has become almost a random target for folks on a political spectrum to kind of push their agenda. That is the only reason why there's a lot of attention at this time in this country on CRT. And the last part of the question, Dion, can you repeat that?
Of course. Why do you think that the disparities have continued to widen despite some of the progress that has been made over the last few decades?
Yeah, so I think that goes back to my discussion of the political determinants. If we don't begin to tackle some of the roots at the foundation, with political determinants really determining what the social determinant is going to be. So where are the grocery stores located? That's due to policy, right? It's due to whether communities actually have the wherewithal to say, we need a grocery store here, or we don't want a gas station here, or we don't want McDonald's here. That's all to our city council, and all those kind of things. So you can think all the way up to the federal level. So if we begin to really, I think it's tackling inequities is very complex. And I think it has to be done from multiple aspects and ways. We need to tackle them at the political level, directly at the social level, and much more so directly at the patient care and clinical level. So there are varieties of ways that we can tackle disparities, but I believe that until we address those political determinants, we will not be successful in eliminating disparities and health inequities as a country.
We have another two-part question. First part, so when are you going to start teaching this course at HSC or on main campus? And then second part is, how do we combat implicit bias that has historically marginalized people's experience?
Yeah, that's a hard one. We haven't been successful. I mentioned Dana Bowen Matthews' book, Just Medicine. If you have an opportunity to pick up that book, she talks about how we have a system, a judicial system that has attempted to create laws that address explicit bias, but we need to begin as a country to develop laws that make people accountable for their implicit biases as well, which is a very kind of controversial idea. Even today, we haven't done a great job in our judicial system and legislation dealing with explicit bias. But I think that if we can have and begin it, Kimberly Crenshaw, I see somebody put it in the notes, if we can begin to think about and think outside the box about how do we make implicit bias illegal and make sure that there's accountability for that in place, perhaps we will make greater headway. Her book, again, is called Just Medicine, Dana Bowen Matthews.
Okay. I know we are a couple minutes past the hour. I want to be respectful of your time, Dr. Fernander. So please let me know if you have the ability to answer a few more questions. We have a couple more in the Q&A box.
Yes, we can do so. I'm happy to stay a few more minutes, as long as folks stay on and pose questions.
Okay. So the next question is, this individual states that they enjoyed the presentation very much and was just curious, the concepts presented in this presentation, do they apply to any person that identifies as a member of a disadvantaged group? So in other words, do these concepts apply beyond race?
Absolutely. So that, I believe, is the whole premise of critical race theory. Although race is in that title, I think the intention is to address and help people understand and develop, then begin to figure out ways in which to intervene in whichever marginalized or disadvantaged communities that may be struggling, whether it's related to health inequities, educational inequities, economic inequities. Definitely. CRT, as I mentioned at the beginning of my presentation, is cross-disciplinary. And CRT has been applied to various groups, indigenous groups, the experience of Asians in this country, the experience of Hispanics in this country. Absolutely. And I didn't answer that question about when I'm going to begin teaching the course. No plans to teach the course. I'm not sure how we can fit it in into medical education, but I know that we do have an existing curriculum team that has been building an anti-racism curricula into our undergraduate medical education, and work is being done also within our graduate studies program, as well as many of our other health professions programs. We have more work to do, but we have concerted folks and committees who are trying to make a headway and making sure that a lot of this information is being explained, understood, not just amongst our trainees, but our faculty as well.
Wonderful. And I believe you touched on this earlier, but just because it was written as a question, it asks, can you give an example of a political determinant of health and how this drives social determinants of health?
So one that easily comes to mind, voting. Voting is a political determinant. If you're not able to vote on various legislative policies that might be on the agenda, what is it called when you go to vote? I'm losing my words today. Or even if you're voting for someone who you know what their stance is, their stated stance is on a particular policy. So, for example, let's say there's someone who believes that housing, certain types of housing, should only be placed in certain parts of town. And this person has made this person running for political office has made their presence, their stance very clear on the housing question. Now we know, and I've shared with you, that certain areas are more likely to be exposed to higher pollution, higher toxicity, less access to healthcare, less access to fresh foods, and so forth, which are all social determinants. So that's how the political determinant might impact a social determinant that directly impacts health status.
Wonderful. And the last question we have in the Q&A box is, can addressing our own internalized bias play a role in working towards solutions as a community?
We must all, every single one of us, no matter who we are, no matter where we've lived, how we've lived, we all have to consistently, constantly, it's a never-ending process to the end of our days, address our own implicit biases. It's only when we are mindful of doing so can we then move towards what I talked about as becoming compassionate, empathic individuals, where we are open to understanding the experience of others and being able then to create a shared community to advance equity for all people. Our goal is not just to advance equity for African Americans or advance equity for Indigenous populations, but we want everyone to experience health equity. That is our ultimate goal. And unless we do deal with those things on an individual level, it's hard to address them on a larger level. So I would challenge each and every one of us to continue in our life journey in the process of addressing our implicit biases.
Wonderful. And with that, want to express my sincerest gratitude for taking the time out of your day to present this topic and discuss it with the community at large. Also, just want to reiterate in the comments section, there's a lot of positivity with regards to the presentation, saying it was an excellent presentation, very informative, and basically this is a much needed conversation to be had, especially in this current day and age. So thank you. We express our gratitude, and I'll allow Dr. Sanchez to provide any closing comments, and we will wrap things up.
Well, let me just say thank you so much, Dr. Fernander, for an outstanding presentation and your leadership and bringing forth this idea, right? You have served as a co-chair on the planning committee along with Dr. Ellis. So I want to thank you again for stepping up and stepping in multiple ways. And Dr. Ellis also for serving as moderator and the entire team, and also for everyone from the HSC community who participated today, but are committed to supporting the work that you spoke about today, as was mentioned in many of the questions and suggestions. So continue to join us for the rest of Black History Month, and as well as continue to join us for Women's History Month that starts March 1st. Thank you again, everyone.